thank you very much to everyone for joining. I know we've got our participants in, and hopefully that will do well. My name is Morgan Reed, and I am the president of the App Association, and currently the acting executive director of the Connected Health Initiative. I'm here from Fairbanks, Alaska, where we haven't had the sun set in any significant fashion for many days, and won't have it for a while longer. But as one of my fellow panelists noted earlier, I have surprisingly good broadband, and it's actually a pretty critical part to life up here in the north of Alaska. But today we're here to talk about the way that this kind of broadband and telemedicine access can change the lives of patients and providers and make a real difference. And most importantly, the way that the COVID-19 tragedy that is striking the world, and America in particular, has really highlighted something that many of us on this call have been saying for years, and in some cases decades, that the use of digital medicine can radically improve patient outcomes, the ability of physicians to serve their patients in a way that meets the patient where they are, and really highlight an engaged patient world where a patient knows more about themselves, the doctor knows more about the patient, and in a weird way, almost returning to the idea of the doctor that knows you, that can come by your home, that can see you with their little black bag, and make a change in your life to keep you healthy, active, and engaged with the rest of your community. A little bit about the Connected Health Initiative. It is a project that we put together at the App Association to really highlight the importance of digital medicine. And I am honored to have a steering committee that has the wide range of companies, academic medical centers, patient groups that we have. We have brand names like Apple and Microsoft and Intel that you all know, but we've also got companies like Remedy and Podometrics that are small startups that are literally changing the lives of diabetics and physicians and their ways to access it. On this call today, you'll hear from Cody and others with patient groups that can talk about the way that digital medicine affects them. But really, we started from a premise that there are three things that are really the questions that every physician asks about digital medicine. And that is, we usually describe it as, does it work? Will I get sued? And how do I get reimbursed? Because at the end of the day, all of the work that we're doing on digital medicine has to be effective. Does it work? It has to be safe and respecting of privacy and all of those considerations. So will I get sued? And then what's its ability to be reimbursed? Because the reality of our system is we spend a little over $3 trillion here in the United States on healthcare, of which Medicare and Medicaid reimburse roughly $1 trillion. But unfortunately, the modality of using digital medicine is something that has not kept up with the times. And as recently as 3 years ago, I think the number that I saw was out of more than $1 trillion of reimbursement, the Centers for Medicare and Medicaid had only reimbursed roughly 30 million. So that's 0.001% or less of visits through Medicare and Medicaid had been done using telemedicine, remote patient monitoring, and other digital medicine tools. And that's been a huge problem. So fast forward right now, COVID hits, and everyone who's been working on this subject has looked at this and said, how do we change the lives of patients right now? How do we meet people at home? And the news has talked a lot about the idea that physicians have been unable to treat their regular patients because they can't come into a clinic, they can't come into the hospital. Well, one of the realities is, how do we make digital medicine work for the physician so that they can get that? Because reality is that most people who need to see a doctor right now don't need to see a doctor for COVID. They need to see a doctor to help treat their diabetes. They need doctors to see them for hypertension. Future mothers need to see them for a wellness visit for their upcoming birth. All of these elements need to have interaction. And COVID's really changing the way that a physician can reach their patient. So we're not here just to have digital medicine work for those who are suffering from COVID. We need digital medicine to work for the rest of the world, the rest of Americans who need healthcare and who don't have COVID. And so really there are some major changes that were put into place through the PHE, the public health emergency. The first and foremost is the waiver for telehealth reimbursement. These temporary changes have been critical for allowing physicians to be reimbursed for using the technology. And that's really spurred my industry, the technology industry, to make sure that they're providing the kind of tech that we need. The FCC has gone forward and put forward several $100 million, $200 million last total for telehealth grants. The Food and Drug Administration made changes on the way that you can move forward on getting telehealth products through there. We've had enforcement discretion around HIPAA and, really importantly, the Stark anti-kickback law. But unfortunately, this progress is temporary and lapses at the end of the public health emergency. And for Congressman Bill Johnson, who's going to come and talk to us about this next, if that goes away, the impact on his constituents, is monumental and incredibly harmful. So we really need to see some changes that have some permanence. And I'd point to some things that would support Congressman Johnson in this effort. Right now, we just did a survey, a digital health survey of likely voters. 40% of them had had a telehealth visit during the COVID pandemic, and 90% of them said the visit addressed their concerns, questions, or symptoms. 90% found what they needed from a telemedicine visit. 80% of likely voters surveyed said patients should be able to rely on telehealth and other digital modalities, including after COVID goes away. So on this webinar, you will hear from experts that will give you the latest on digital health policy changes, as well as ongoing challenges and lessons that we've learned from connected health. For the question and answer, you can use the Q&A function, and we'll try to get them all answered at the end of the panel. For those of you who are watching our YouTube streaming of this, you can email your questions to Madeline Zick at mzick@actonline.org. But you probably saw that in the email you got that you clicked to get here. But I think last I want to leave you with this. Here's what you need to know from this webinar and what I hope you take away from all of the panelists. We are in a position to take advantage of the fact that more than 80% of Americans have a smart device in their hand. And by the way, in this time where we were talking about all the social issues that are going around, that crosses all lines. 80% is something that we see for people of color, for rural folks, for urban folks. Having a smart device, regardless of platform, is common. It's widely available. Broadband, that's sometimes in question, but the device is something that most Americans currently have. So let's figure out how do we take advantage of what people have, meet them where they are, and give them the healthcare that they need in order to succeed in their lives. And I think one of the leaders on this who has been at the forefront of this issue has been Congressman Bill Johnson. I'll do the formal part, Congressman, really quickly. Congressman Bill Johnson represents the Ohio 6th District and co-chairs the Congressional Telehealth Caucus. Congressman Johnson served in the Air Force and retired as a lieutenant colonel after a distinguished military career of more than 26 years. I don't know if you ever got up here for the Air Force Base here in Fairbanks, but that's too bad. It's well known, cold, but an interesting place. He has, as co-chair of the Telehealth Caucus, he and Representative Matsui have really pioneered the idea of a general waiver from telehealth originating sites and geographic restrictions for Medicare patients. You'll hear more about that from some of your panelists. And was a huge support that was the Evidence-Based Telehealth Expansion Act of 2017. And this Congress, he is again co-lead on the Connect for Health Act, the broader telehealth measure. You heard all of us mention the broadband element of it, and I should make a moment to highlight Congressman Johnson's support for his push for the FCC, calling for the use of TV white spaces and that rule to be finalized. That is absolutely critical for the more than 20 million Americans, especially in rural areas, that don't have access. And frankly, it's just not cost effective to pull fiber to their house. So Congressman Johnson, thank you for your support on broadband and TV white spaces. And we appreciate Congressman Johnson and his co-chair, Representative Matsui's bold leadership on this and his recognition of digital health's key role in the improvement of outcomes in a cost-effective manner. And with that, we are honored to have you with us today. Tell us what you're working on and let us know what you think is the most important element of going forward on digital medicine.
Well, Morgan, thanks. And no, I never actually physically stepped foot in Alaska. My luggage made it there one time, and on a trip, it got rerouted, and I spent 3 days without any clothes. So at least parts of my repertoire made it to Alaska. But you asked a question earlier that providers are asking. Does telehealth work? And I think the answer is unequivocal. Yes, it absolutely does work. And I'm going to point out some statistics here in a moment that'll help highlight that. But look, thanks for giving me an opportunity. I'm an IT guy. Both my graduate and undergraduate degrees are in information technology. I'm a patent holder. I understand the power of information technology. I also understand the need for social responsibility around information technology. So it's really an honor to be with you. And I want to thank the App Association, as well as you, Morgan, for all of your hard work and support in expanding this concept of telehealth. And broadband, because, without broadband, telehealth doesn't work. And in many rural places of the country, like eastern and southeastern Ohio, we struggle with access to broadband. During this pandemic, as Morgan, as you have noted, and the associated lockdowns, Americans all over the country have struggled to keep up with medical appointments, many of those Americans being at risk, and some of them like chemotherapy patients. They're fearful to leave their homes for even essential care. I had a provider in Belmont County, one of my 18 counties, who had a problem getting his internet service provider to connect his fiber connection into his home so that he could care for his oncology patients without having to get them out of the house. And I was very, very disappointed that it took us almost 4 weeks to get the internet service provider to go do that. But chemotherapy patients, for example, are some of the most vulnerable to COVID. They could die within hours of contracting the virus, not days or weeks, because of the lowering of their immune system. But thankfully, and with the support from folks like you and many other provider and patient groups, my colleagues and I were successful in leading the charge to get those temporary waivers in the second COVID package for many of the burdensome telehealth barriers that were keeping people from being able to take advantage of telehealth. And so I'm pleased that the administration took this authority that we gave them in the second COVID package and really hit the ground running. And CMS did a really good job of getting the guidance out and helping providers build out their telehealth capability. They answered many of those questions, Morgan, that you talked about. Does it work? How do I get reimbursed, et cetera? And as you might have guessed, and I know we're going to be talking about it on the panel today, both providers and patients that we're hearing from were very, very pleased with the results. Easing those restrictions, increased access to essential care, and it helped to prevent overcrowding of the hospitals. That's what the whole flattening of the curve was all about. We knew that if we could flatten the curve and avoid overwhelming our hospitals, People that were in their 65 age group and older were the ones that were really threatened by this pandemic. And that's where most of the deaths have occurred from, although there have been some younger folks that unfortunately have died as a result of the pandemic too. But it was overwhelming of the hospitals so that there wouldn't be any room for heart attack victims or cancer victims or diabetic issues, essential surgeries, and et cetera. So while the isolation and the lockdowns have been an inconvenience for many Americans, many individuals, particularly those that live in districts like mine and rural areas across the country, they deal with isolation even in normal times. And so their eyes have really been open to the power of telehealth. And that's why enabling telehealth permanently is so very, very important. And I'm going to continue to work on that issue. Last week in the Energy and Commerce Committee, I had an opportunity to question Dr. Fauci, Admiral Giroir, and Dr. Redfield on the benefits of telehealth during COVID. And Admiral Giroir gave some really telling statistics. He noted that the week of January 15th of 2020, there were only 500 telehealth visits by Medicare that were billed through Medicare. By the week of April 15th, there were 150,000 of those telehealth visits that were billed through Medicare. So this is proof positive that cutting back on Washington red tape and bureaucratic barriers makes a difference to the American people in terms of delivery of health care. So as you mentioned, Morgan, I'm a co-chair of the House Telehealth Caucus, and I work very, very well with my co-chair, Doris Matsui, and I'm very, very proud of the work that she and I have done together. And I'm going to continue to work hard to advocate for permanent changes. And so you've got my commitment on that. I don't want to take up any more.
No, I want to.
But I appreciate it.
I want to take my president's prerogative here for a moment and ask an important question. What help can we, the public, provide you? Because as our surveys showed and what you just said is patients are finding real value. And hopefully we'll hear from some of the physicians on the call about how physicians are finding real value. What will help you in encouraging your colleagues in Congress to pass permanent changes? What can we do in the general public?
Yeah, I think, number one, keep doing what you're doing, because sessions like this today will give me cannon fodder to go back and talk about that. We're talking to people all over the country. We're talking to experts in healthcare delivery. We're talking to mental health providers. In the hearing earlier this week, I spoke with mental health providers and talking about how critically important it is that people that are struggling with mental health disorders, whether it's through substance abuse or whether it's a result of the anxiety caused by the pandemic, that it is, it is essential that they have access to mental health services.
Absolutely.
And, so keep doing what you're doing, and we're going to keep pressing forward to make sure that our colleagues understand it. But here's an important point. I don't think there is a lawmaker or a decision maker from local to state to the federal level. Even though the pandemic did not cause the urban-rural digital divide, there's no one that's in a decision-making capacity in America today that doesn't understand that access to broadband, access to high-speed internet is as important in the 21st century in a digital world as electricity and plumbing are to economic growth and opportunity. And with access to digital broadband, that brings ever-expanding access to telehealth. I have known for a long time that healthcare providers were not the stumbling block, and patients were not the stumbling block. It was the bureaucracy and the federal government dealing with licensing and certifications and reimbursements, and those were the stumbling blocks. And we sort of got rid of all those barriers during the COVID crisis, and now we need to work to make those permanent. I think you're going to see a bigger outcry. It's going to be a lot easier sell going forward than it was before COVID. So if there is a silver lining in a very dark cloud, that's one of the positive things that we've learned throughout this entire ordeal.
Thank you very much. And I think it's really important to note how much work you've put into this before. When we were talking before we started this, I noted the fact that our lawyers and folks in our organization and our steering committee puts together 100 plus page filings with CMS and FDA describing each regulatory barrier and the way they stack up. And even unintentionally, one of the things that's been talked a lot about this in the current time has been, how is this affecting different communities? And one of the obvious examples is, you don't even think about it, but because of the restrictions on telehealth, the 1834M section, the requirement for originating site, that it can only be in a HPSA, that's a a census determined health professional shortage area, all of these things. Well, it's easy to say to an urban, and somebody who lives in a larger city, well, you've got a doctor within 5 miles or 6 miles, you can drive, except they might not be able to. They'd have to take 2 buses, cross over the tracks, go to a place that they don't know for a doctor that isn't part of their community. And the originating site requires them to participate at a health clinic. Well, guess what? Their community doesn't have a lot of health clinics. So sometimes the regulations that are in place not only put barriers that are obvious, but they stack up in a way that hurts a lot of communities that nobody even thought would need that. So you're right. Broadband is critical. Getting rid of those barriers like originating site that forces people to go to a health clinic that they don't have in their town just to do a telemedicine visit with a physician. It's harmful at every patient level. And I think that's something that you've done great work to remove. And I think it's really important that we talk about it from the concept of, I've never found a member of Congress that I've met with that says, I don't want telemedicine. I want to get rid of it. You and your colleagues we have members in all 435 congressional districts, and I've met with a lot of members of Congress. They all support it. But the question they ask and that you've been answering is, well, how do I get to yes? How do I get there? Your legislation and the work that you and Matsui are doing has been really critical to giving an answer to your colleagues about, I get it, but I need a roadmap to get there. And so we want to support your continuing work with anecdotes and patient stories and evidence so that when you go to your colleagues to say, here's the roadmap to making your constituents healthier and your doctors happier, you have a roadmap.
Well, you said something earlier that I think is very, very true. And I don't think many Americans that have never participated in telehealth view it this way. But this really does take us back to that personal touch by your physician, the physician that that you can get access to anytime you need to, and it brings that physician right to your home. In a digital world, it's almost back to that circuit riding physician that grabs his bag and gets in his horse and buggy and goes from house to house doing his wellness checks and going out and birthing babies and wiping fever from people that have typhoid and all of those kinds of things. This puts a very personal touch back on healthcare, because when in spite of the fact that we are miles and miles apart, even something as benign as this Zoom session that we're having right now, it seems like a very personal connection. When you're talking to someone over a Zoom, there's a one-to-one exchange of communication. Both sides of that equation feel valued in that relationship. I think it motivates in relation to healthcare. I believe it motivates the provider and it motivates the patient in a very positive way. So I think there's a lot of good that can come out of this.
Well, I hope so. And I could talk most of the day about digital medicine with you, but we have a great panel, and I want to thank you for joining us for this. And I want to turn over the session to Chelsea Thomas, the Executive Director of the App Association, and a real star-studded panel of physicians, innovators, advocates for the patient community and others. And Chelsea, are you ready to take the reins here with Zoom?
I am. Thanks, Morgan.
All right. Thank you very much. And I'll listen.
All right. Thank you so much to Morgan and Congressman Johnson. As you all just heard, the COVID-19 public health emergency created an inflection point to utilize digital health tools, not just for treating the virus, but for delivering everyday care to patients. To discuss how patients and providers are using these tools and what the future holds beyond the public health emergency, I'd like to turn it over to our panelists to briefly introduce themselves and say a few introductory remarks. Let's start with Dr. Ruban.
Good afternoon. Are you able to hear me now?
I am.
Okay, let me put my video on. We should be ready to go. All right. Well, greetings from the University of Virginia. I'm Karen Ruban, and I direct the Center for Telehealth at the University of Virginia. I want to thank the App Association and the Connected Health Initiative for all the advocacy work you guys have done. It's been phenomenal. And I want to thank Congressman Johnson for his amazing work leading the caucus and for his legislative support. I myself previously lived in Ohio. I know his district well. I'm a graduate of the Ohio State University College of Medicine. And I have to say his district is very similar to the districts of the Commonwealth of Virginia that we serve, Appalachian Virginia in particular. So I direct the Center for Telehealth. I'm a pediatric cardiologist. And, I guess we're starting with introductions and you'll have questions afterwards. Is that right?
Yep, absolutely.
Okay.
Thank you.
Thank you.
And Dr. John Brownstein.
Yep. Hello, everyone. Thank you for having me. It's a real honor to be part of this event. My background is actually, I wear two hats. One is I'm an infectious disease epidemiologist. The other is chief innovation officer. So I have two very different perspectives on this pandemic. One from running a group that has been doing early detection of this virus all the way to late December, building technologies using AI and crowdsourcing to actually identify the emergence of this disease early on in populations, and building tools to support the CDC and local public health as they respond to this virus. But on the other hand, trying to build digital tools to support our patient populations at Boston Children's Hospital, where clearly digital tools are just as important for pediatrics as they are in the adult population, and how large a population we have in the Medicaid space. And through that role, has spent a huge amount of time to reshape how we deliver care. Now, it's a sort of a one-off, it's not just a one-off situation where we have a transient effort in digital. We've sort of been able to really change the way that we provide care, which I think ultimately will be something completely different going forward, whether it's scaling our virtual visits, going from 20 visits per day to over 1,800, to launching chatbot tools to help call volume, to symptom checker declarations, to remote registration processes, digitizing our intake, bidirectional text messaging. So there's a long list of features of things that we have attempted to do for many years, but have not had the ability to. And now we have sort of the right substrate to do this and do this sort of for the long term. So again, great to be here and be part of this discussion.
Wonderful. Thank you. And Colby Tyner.
Thank you very much. I'm always happy to be a part of these discussions with the App Association. I've known Morgan for quite some time, and I've been involved with various coalitions around DC with Morgan. Again, I'm just very glad to be part of this conversation. I'm a health policy analyst for the American Heart Association. As such, the majority of my portfolio covers telehealth, remote patient monitoring, digital health, virtual care, whatever term you wanted to use for it. We take the patient access route when it comes to telehealth. We understand, of course, that the science is very clear, the potential benefits for telehealth, but there are certain things that have to be included in order to ensure that everyone has access to its potential benefits. You talk about things like self-efficacy, usability, health literacy, digital literacy, broadband access was brought up, some of the cultural barriers. Again, we fully understand and we fully know and we advocate for increased access for telehealth. But as with any other protocol, healthcare protocol has to ensure that everybody has access to its potential benefits. So I'm glad to be part of this conversation, and it's a very important one.
Wonderful. Thank you so much. We'll just start right now with a couple questions for you, Dr. Ruban. You testified a couple of weeks ago in the Senate Help Committee on how telehealth is playing a role in addressing the COVID-19 pandemic. What was your message to the committee, and how do you think your message was received by the members of the committee?
Oh, thank you, Chelsea. I thought it was a terrific hearing, and I was so delighted to see and hear the bipartisan support for making some of the changes, hopefully most of the changes and waivers in the Medicare program, Medicaid programs, and commercial plans permanent. We ourselves, just like Dr. Brownlee shared, we ourselves have expanded massively. We've seen a 9,000% increase in the utilization of telehealth. And there are many elements of the waivers that helped enable that to happen. The 1834M restrictions have been very restrictive for us and for our patients. And as an academic medical center, we've previously mostly served the western half of the Commonwealth of Virginia with very rural constituencies in Southwest Virginia, again, much like Southeastern Ohio, where distance is a challenge. And unfortunately, the 1834M restrictions created major challenges for our patients, because even patients who live in communities that were that by all stretches of anybody's imagination seemed rural, they still were. They were considered living in urban areas, some of our most rural regions. So the HPSA designation primarily were, about primary care, but access to specialty care remained a gigantic problem in those communities. So we replaced in-person visits. We expanded remote patient monitoring. We've created expanded educational programs. We've established telemedicine connectivity in long-term care facilities and skilled nursing facilities very quickly, where there have been congregate settings with high rates of infection. And I thought the message was truly heard, and I look forward to elimination of further restrictions. The other piece was, again, we advocated for broadband expansion, and I'm very grateful for the Federal Communications Commission responding to the CARES Act and launching the COVID-19 telehealth program, and the rules will be coming forward for the Connected Care pilot program, which will enable broadband communication services to the home of patients, which will be really low-income patients and veterans. So we look forward to participating in that as well. So again, I thought the message was heard, and I was delighted with the bipartisan support.
Thank you so much. And I think that you touched on a couple of the interesting things around the ways that telehealth can help address inequities. And obviously, there's been a lot of conversation around and concern about that, because often you need an internet connection at home to take advantage of telehealth or digital health services. Those who lack those facilities are left behind. But as you mentioned, that's not the whole story. And in order to enable equitable access to these critical services, we must first remove the restrictions in statute, right? They're waived now during the public health emergency, but at a minimum, we need to be able to remove them in statute in order to address the inequities, right?
Absolutely. I might also add, though, that we are very grateful for the waiver to include telephone codes, because our patients would have been in islands by themselves if we didn't, the broadband challenge remains a challenge, but we needed to be able to connect with our patients wherever they were. And so that's really important that those endure as well.
I was also wondering if you could talk a little bit more about the Federal Communication Commission's telehealth pilot. I know it came up during the hearing, and it would be great to hear about ways that can also ensure that there's connectivity, and for underserved communities especially.
Absolutely. So we've been long participants in the rural healthcare program from the inception of our telemedicine program, because, again, many of our patients are from rural regions of the Commonwealth of Virginia. but the requirement was that they be a not-for-profit facility. So, and as we heard from Morgan and we heard from Congressman Johnson, facility-based care isn't the only solution. It's very difficult, especially in a pandemic, for patients to even consider going to a facility. So the commission approved in their recent, they approved the rulemaking for the $100 million Connected Care pilot program. And the RFP hasn't been launched yet, but it will be shortly because they've been very busy with implementing the COVID-19 program, which we are also very grateful for. And happy that we were an awardee notified last week to allow us to deploy technology to the homes of our patients. But the $100 million Connected Care pilot program will bring that bandwidth to the home of our patients, which will be critical as we try to expand home-related services.
Wonderful. Thank you so much.
Sure.
Dr. Brownstein, you also testified in front of Congress recently in front of the House Science Committee, which actually seems like a lifetime ago. It was a couple of months ago. Yeah. And you noted that with a pandemic, there tends to be a dangerous cycle where amazing strides are taken initially, and then when news reports die down, our unified response fades away. And this is exactly the cycle we're up against with digital health and telehealth. Policymakers saw the value of it, and our concern is that the old objections, cost, equity, fraud, and abuse concerns will reemerge and prevent permanent reform. How can we help policymakers break this cycle of sort of crumbling resolve?
Yeah, it's a big problem across the board, not just telemedicine, but being in the public health front where you get a major crisis, you get investment, and then slowly those dollars slip away. And we've dealt with that in the public health community for so long. And I think clearly we have that fear here with telemedicine. Now, the good part is that we're not, good or bad, I guess, is we're not out of the woods at all with COVID. And now we have a threat of potentially a bad influenza season. And so we're going to have sustained amount of risk and a need for telemedicine, which I think is very different than some of the other sort of spikes in news cycles that we've seen. But at the same time, I think, we need to think about how the digital and virtual initiatives have been framed prior to COVID as more sort of around their convenience. And now we can think about them much more essentially, right, as for patient safety and infection prevention. And I think this is an important reframe. So for COVID, but also beyond. So at BCH, we've seen how sort of virtual care enables the extension of care for immunocompromised kids, extends reach for those that have been marginalized. And so I think the cat is somewhat out of the bag. I think there's now an expectation on our patient populations that this is going to be here to stay. What balance between virtual and in person, I think we still have to sort of figure out. But the patients are going to demand this. And I think the reality is we're going to have another pandemic. We're going to have some other event that really is going to put pressure on some of these issues like licensure requirements and reimbursement. And the data will speak for itself. The reduction in no-show rates, the extension of reach, especially in our Medicaid population, I think is going to be sort of enough data to point that we're sort of in a new world going forward.
Absolutely. And I think that that's something that policymakers are sort of grappling with right now. A lot of the intractable problems that they are dealing with is how do we ensure that providers and patients can access these telehealth and digital health services? From your perspective, how has the availability of connected health tools like these benefited efforts to stop the spread of COVID-19?
Yeah, I think there's a broad set of questions in that. So there's tools that have been broadly available, like symptom checker tools and contact tracing tools, exposure notification. There's a whole range of tools that have been launched. And this is incredible to see sort of Silicon Valley companies getting in the mix, building partnerships like we saw with Apple and Google, or the efforts that sort of Microsoft has been involved in, and even Facebook making their data available. So we've seen this incredible sort of partnership that's happened between health systems and large-scale companies that really have resources to deploy in a way that, as a public health person, I would never have expected. And even beyond that, some of the connected devices and wearables that do continuous sensing that can provide early insights into symptoms. We've seen the proliferation of chatbots and tools that can engage people, especially when you have a limited workforce. So I think it's been incredible. The amount of innovation has been sort of staggering when you sort of look at, a lot of people focusing on one problem. And now the issue is, are we going to see sustained investment and support of these tools going forward? And I think that's what we're, incredibly hyper-focused on right now.
Yeah, and I appreciate your mention of, the tracing apps. And at the time of your testimony, there were just 62 known cases of COVID-19 in the US and 2 confirmed deaths, which it's kind of mind-boggling between now and then. And you made a strong case for the federal government to invest more in understanding spread patterns, including through the use of data-driven tools like Flu Near You. Fast forward to now, and we see that the disease has ravaged our communities. And I wonder to what extent we could have better enabled tech tools to help contain the spread. And what are your thoughts on this? And are there ways in which non-traditional data sources could support containment and tracing efforts that especially benefit communities that have been hit the hardest?
Yeah, I mean, as you know, with the emergence of COVID, we had a real deficit in testing availability, and that put a huge strain on our ability to respond, unfortunately. And that was probably one of the major reasons why we never got a handle on this pandemic. But it also pushed for other innovations in the space. And so we launched a platform called COVID Near You, which has symptom tracking capabilities, which essentially crowdsources insights about symptoms in a population where you don't have testing. And we've shown through some of our research that there is huge disparities in access to testing even today, despite the fact that we're doing 500,000 tests a day right now. And clearly the data has been lacking, especially as we see the rise in cases across the southern part of the US right now. But these technologies are incredibly valuable to get sort of a handle on what's happening, not only to understand new epidemics that are flaring across the country, but to be able to forecast the disease, to be able to model interventions, and then importantly, be able to feed that back into clinical decision making. And I think that's another place where there's been a lack, huge amount of innovation, a lot of data being produced, but not a lot of that being fed in to clinical decision making to help patients that are potentially exposed. And so that's where I think there still needs to be some work. And then the contact tracing part of it as well, where there's sort of a limited deployment. And so we need to figure out a national strategy and whether we're going to do app-based contact tracing, humans in the loop, some combination. So still a lot of these issues to figure out going forward as we head into potentially, the second wave of this pandemic.
Yeah, absolutely. And obviously, one of our jobs as the Connected Health Initiative is to continue that drumbeat. What are different ways that you think that these capabilities can benefit patients and caregivers after the public health emergency ends, after sort of like the big news? It's hard to imagine it ever fading from perspective, but how do we keep that drumbeat up and how are the folks benefited?
Well, I mean, so similarly, this FCC investment, we actually were one of the now recipients, the first one in Massachusetts, for the work that we're doing. And I think that's a massive investment for us in the piloting of these sort of connected remote patient monitoring devices. We're working with a couple different companies. They're doing connected devices, both in sort of medical exams and also in the cystic fibrosis patient population, with given their particular vulnerabilities to COVID-19. So, that funding in itself is going to create at least initial data to recognize the value. It's going to create additional sort of input for us on how patients are willing to utilize these devices as a sort of a supplement to the care. I mean, clearly we need to spend a lot of time thinking about thoughtful, inclusive design for these offerings to be broadly well adopted. So again, these are the kind of funding streams that are going to provide us the kind of data that we need and understand sort of what outreach and education is going to be required, because it's not just enough to sort of develop these tools. We have to understand how they're deployed in the community. So, again, the investment we're seeing right now from the federal government absolutely is going to help us sort of overcome this hump when that news cycle starts to really die down.
Absolutely. Thank you.
Thank you.
And Colby, talking about things that Congress can do and ways that they can look at removing regulatory barriers. One thing that we have long said that Congress can do to improve access to remote patient monitoring for heart conditions is to remove the copay requirement. That's a statutory requirement for Medicare to cover 80% of remote patient monitoring services, with a concomitant requirement for the provider to collect the remaining 20% from the patient. How are RPM services beneficial for patients with chronic heart conditions?
Extremely beneficial. Just taking a step back here, we all know from the science that the more personalized healthcare is, the better impact it's going to have. Remote patient monitoring allows physicians to have a more personal touch with the patient's healthcare, because the whole idea of it is to give physicians 24/7 access to the patient's data. What that does is that it allows them to have, it allows them to analyze trends either in the positive direction or the negative direction. It allows them to understand what the patient's normal is. So if you're a hypertensive patient, your baseline might be different from somebody who's non-hypertensive. Of course, it's based on your age, your demographics, where you live, what your diet is. Remote patient monitoring allows the physician to understand what that is and to understand what might be abnormal, if that patient's trending in the right direction with what they're doing, or if they're trending in the negative direction. If they get an abnormal reading, it gives them an alert and allows them to make decisions accordingly. So to make a comparison here, imagine if epidemiologists, or lawmakers for that matter, relied on COVID data as it was coming in that was only at 4-week separate snapshots. Do you think they would know what the normal is? Do you think they would know if we are going in the right direction or the wrong direction? How do you think they'd be able to make beneficial decisions based on data that's incomplete? So remote patient monitoring does that. It's 24/7 access that allows physicians to provide more personalized care to the patient. And so in the end, across the system of care, let's say, again, you're a hypertensive patient, you're in the pre-hospital space, you've been newly diagnosed. Physician can say, okay, I know when you have breakfast in the morning. I know when you tend to exercise. I know when you tend to take a nap, when you go to bed at night. So I know what your readings are typically as a hypertensive patient at all these different points, and I can help you make better healthcare decisions. In the post-hospital space for stroke rehab patients, it allows a physician to understand if the patient is actually engaging in behavioral change. Are they moving more? Are they eating a better diet? So in the end, number one, it helps them to reduce the likelihood of initial hospital visit that tends to be costly. And secondly, in the post-hospital space, it helps them reduce the possibility of readmissions. So it's more personalized care that telehealth and RPM provides.
Absolutely. And yet, despite the life-saving capabilities of these digital health assisted cardiac recovery programs, one of the recent studies that you pointed us to shows that only 1/3 of those who are eligible actually sign up. And Black Americans are among the least likely to sign up, with the copay listed as the main barrier to uptake. Couldn't removing copays help enable better access to life-saving digital health services for minority patients?
Well, in our society, healthcare is still a commodity, so obviously payment is the ultimate barrier. But aside from that, let's assume that the patient is capable of paying, that does have insurance that covers it. There are certain cultural barriers. For example, you cited the study that I brought to you regarding African Americans and the fact that they are less likely to receive cardiac rehabilitative services. We know that African Americans as a whole are not likely to be treated as aggressively as, say, white patients. They're more likely to live in areas that lack access to cardiac rehabilitative services. They're more likely to live in areas that have access to specialty services that they're able to refer. Since we're moving into a more digital world, they're more likely to live in areas that lack access to the adequate technologies that are necessary for this. So the payment is important, yes, but what often gets missed in this digital health discussion is that there are technological barriers, one, and there are cultural barriers that add on top of that, that decrease access to healthcare services.
Absolutely. Near the beginning of the public health emergency, HHS made an important determination on remote patient monitoring. Specifically, the agency decided that for purposes of RPM payment codes, the patient need not be in a managed service. And instead of having to have a chronic condition, the patient could have an acute condition like COVID-19.
Mm-hmm.
What is the impact of this decision in the near term and also in the long run from your perspective?
Well, I mean, Dr. Bronstein touched on the impact in the near term on this decision, because obviously COVID is an acute situation. It's an acute healthcare condition. It allows patients to, number one, who may need quarantine, but to stay away from the hospital, and it reduces the risk of the disease spread. It has potential to reduce their anxieties in quarantine by keeping them in contact with their physician and with maybe their home health aide or their family members. But moving beyond COVID in the long term here, I think we often think of healthcare in the terms of the chronic condition realm, because the chronic condition patients, I think Morgan was citing that 5% of them actually take up 50% of the healthcare costs in this country. And we're talking about things like Alzheimer's, hypertension, congestive heart failure, chronic conditions like that. But most of the primary visits that actually do take place are acute conditions. And we're not just talking about things like strep throat or pneumonia. We're talking about things like a sprained ankle. A sprained ankle is, in fact, an acute condition. And to give an example, the first month into the shutdown here in Virginia, I became a runner again. And I unfortunately sprained my ankle. I did not want to go to the hospital or my primary care physician at a risk of, obviously, due to the situation here. But telehealth allowed me the chance to be seen by my physician, and he actually walked me through a stress test over Zoom. Now, obviously, I'm not a Medicare patient, I'm not a Medicaid patient, but assuming if I was a Medicare patient, that provision would allow me to, my physician to get reimbursed and allow me to get reimbursed for being seen for an acute condition. So in the long term, it's just these basic primary care visits that will be covered. It's flu infections, it's the common cold, it's sprained ankles, things of that nature. So very, very important. In regards to the managed care, I'm not going to get into the weeds of whether telehealth should be more beneficial within a managed care system or without. But I will say this, a lot of the managed care programs these days are becoming much more comprehensive in the telehealth coverage they do provide. Centene, for example, the largest Medicaid provider in this country, has a very holistic coverage regarding telehealth. And they go into some of the social determinants of health, like the patient's access to broadband access, making sure that they have access to the necessary technologies. And two, also important, is ensuring that they have the education to understand how to use the devices. But also for immigrant populations who English may not be their first language, they are providing services that are linguistic, that provide interpretive services so these populations can use telehealth. With that being said, if you're a patient in a rural area who you've just been bumped off your insurance, you're unemployed, you lack access to a managed care program, entities such as Teladoc are filling that void. And it's no secret that their stock price went through the roof once this pandemic hit. They're filling that void. They're not necessarily within managed care programs, but they do have a role to play. Now, the complaint is obviously, and I don't really want to necessarily get into the weeds of this, every time you go to a Teladoc appointment, you most likely are getting a new physician. So it's hard to get that personalized care. But the void is being filled. So I don't know where that direction is going to go once this pandemic ends. But there are beneficial roles to play for both the managed care position and both the direct-to-consumer offerings.
If I could make a comment on that, Chelsea, if you don't mind.
Absolutely. I think, please.
Broadening the payment coverage and eliminating a lot of the restrictions will engage providers to be able to offer this for their own patients in the primary medical home and even in the specialty medical home. So I think that's really important, because we do think patients need a medical home as much as possible, right? So having some of the barriers removed will incentivize providers to engage all the more so. And patients do, the Press Ganey surveys have been incredibly impressive in terms of patient engagement and patient support for the use of telemedicine. And as Dr. Brownstein said, patients are, we'll test this model, but we are learning they love it. The genie, I don't think, is going back in the bottle from the perspective of the patients.
Well, and it's quite a genie, if the way that Representative Johnson discussed from January at 500 to 150,000 in April, it's it's hard to imagine that sort of that exponential growth could be tamped back down to pre-COVID levels.
Dr. Rubin, if I may ask you, can I ask Dr. Rubin a question actually?
Sure.
You practice in a rural area, for example, and we've been talking about the patient perspective. From the provider end, one of the things that has come up in the literature is the implementation costs of telehealth for providers, particularly in underserved areas. When you all began implementing or expanding your telehealth program, what sort of issues did you all come up with when it came to procuring and implementing?
Sure. So those are challenges, of course, because we did not have an enterprise platform to convert all visits to virtual, and we had to scale to address the needs. So I'm part of an academic medical center, but the system is looking at the value proposition and ROI for a major investment in order to serve our patients the way we want to. And so that, it does take a financial analysis for a system to be able to invest in that. And the same is true really for individual providers and practices as well. So having these waivers continue supports our continuation of that and making of further investments, as well as education as well, educating our providers across the disciplines.
Yeah, because I think Harvard came out with an analysis earlier this week that traced the trajectory of telehealth visits during the pandemic. Obviously, there was an initial peak, but recently they started to not dovetail, but decrease a little bit. And of course, one of the things that was brought up was that there is the uncertainty of the future of these waivers. I think the administration came out, I think it was yesterday, and at least hinted towards the fact that they were going to, number one, increase the PHE, but to ensure that some of these waivers are going to be made permanent within the next physician fee schedule, if I'm not mistaken. So I think there's some hope with that, but the telehealth visits have started to decrease a little bit due to that uncertainty.
Right. And I think as we look at investments and even looking at the federal government's investment, how $200 million from the FCC Connected Care pilot program, we need to continue this trend and not pull back and make it worth the investment for the entire ecosystem of healthcare.
Yeah, and that's something that has been a priority for the Connected Health Initiative is finding ways to work with lawmakers to help them understand the importance of extending these waivers beyond the end of the public health emergency. But making sure that they're aware that the life-saving benefits that these technologies are providing, and that it's not specific just to COVID. Sort of Chelsea, the broader implications.
If I could add one more thing, alignment across the payers is going to be really important as well. John's group is a children's hospital. I'm a pediatrician. I mean, we're talking Medicare, but we also need to make sure and ensure that there's alignment with the Medicaid programs as well. Very important in the commercial plans as well. And each state has its own telemedicine, for Medicaid at least, and for private pay parity reimbursement as well. So alignment will be very important in terms of the business modeling for providers who are going to be making these investments. Yeah.
Dr. Brownstein, were you going to say something?
No, I just was appreciating Karen's mention of Medicaid, because it clearly is just as important. And, that 40% of Medicaid are kids. And so we need to be thinking about, the access for that population just as much. So I appreciate the mention.
All right. Excellent. Well, thank you. Do any of the panelists have anything else that they would like to say before I go to the questions that we've received from the audience?
Oh, go ahead.
Nope. That's great.
All right. Well, the first question I have is on broadband access. In a recent Senate Help Committee on Telehealth, Senator Burr stated that funding for broadband access may not be anything we need to worry about in light of the Starlink project happening in the private sector that should make broadband accessible anywhere at low cost. Is that realistic? And if so, have you heard what the time frame is for that happening? Have you guys heard anything on that?
No.
You're not depending on Starlink?
No.
Nope.
We are not.
No. All right.
I will say this though. The White Spaces project, one of the reasons why white spaces are being considered is that it's already existing infrastructure. So it would negate the cost of any kind of upfront, shovel-ready project. This is infrastructure that already exists that is unused. And what white spaces are is that they create the buffer zone for incoming feeds that protect them from static. And so it's intended to reduce the cost of any kind of implementation of broadband access. I don't know anything about the Starling project, but that's the reason behind the white spaces.
Excellent. Thank you. Another question is, does telemedicine require better internet quality of service metrics? Currently, our practical metrics are binary. You have broadband or you don't, or subjective and non-empirical. As Morgan said, his broadband is, quote, surprisingly good. I ask because doctors providing services might need objective and empirically measured quality of service.
Mm-hmm. Yeah, I mean, we're doing this across the board at Boston Children's. I mean, it's not just a binary sort of understanding. It's trying to understand the ability for people to be able to access the tools that we're providing. It's the quality of the video. It's the service disruption. So we definitely had situations with certain vendors that we've had sort of dropped calls. And so I think it's much more broad in terms of how we're accessing, how well the product is being delivered rather than just whether a patient has access to, broadband or not. Clearly, people are using it off of LTE and eventually 5G. So there's a broad range of ways in which people are also accessing these services. So clearly, it's more complicated than sort of just a yes or no question.
And I would like to say, for us, we have been tracking performance metrics of our connectivity for our facility-based telemedicine program, but I think we haven't implemented yet those types of metrics for the home-based services. But I would imagine that is going to be an important. Quality of service is important. Calls that are dropped are not functional, and we don't want to have to revert to telephone unless we have to. So I think performance is important, and as we scale to homes and continue that's going to be an important evaluative metric as well.
Yeah, and I would also add just a couple different points here. There's actually quite a bit of recent research that points to, assuming a patient does have access to broadband or the necessary technologies, there's a certain degree of data plan or internet speeds that is necessary for some telehealth visits. And if they don't have access to that, then the quality of the visit is not going to be very good. Certain telehealth visits that involve data transmission or image transmission, they actually do require a more comprehensive data plan and higher internet speeds, as opposed to maybe just a follow-up consultation that require just a basic, video chat. Or the second point is that one of the most important waivers that was implemented, and I've heard a lot of this from physicians, is you're no longer required to have a both audio and video hookup to get reimbursed. You can get reimbursed for only use of telephone. And a lot of physicians will now say that many of their telehealth visits, whether just for consultation or follow-up, only a phone is necessary. And the reason being, audio and video, as opposed to just audio only, it's much more expensive. And it is a barrier in and of itself. If you want to get reimbursed previously, you had to have both audio and video. And that left a lot of people out in the dust.
I want to follow up on that. I used my prerogative to get back on the call here for Karen and John, and actually, Colby, it goes to you as well. I serve on a Health and Human Services Federal Advisory Committee, and in our last meeting, what came up that I hadn't honestly thought about enough was we had several providers saying that a lot of communities, they have smart devices, but they don't know how to engage with a physician over telemedicine visit, and that there's no reimbursement for a clinical worker to do an advance call with somebody to say, okay, so you have a virtual visit. Here's what you need to prepare, find a room. Here's what you need for record. And that I don't want to call it tech support, because it's a little bit more of getting people used to the sense of going to a virtual visit. And that requires time of your clinical staff or your support staff, and not necessarily the doctor, but there's no reimbursement code for it. You have to eat it in your E&M. Can you talk about, especially for communities where they may not be doing a lot of Zoom calls, and trying to figure out how do you as a physician engage with them better? And is that something where a code would be helpful so that you can have staff do that and reimburse for it?
Yeah, I mean, it's a great question, because right now there's no reimbursement for that kind of work. That clearly is effort that the hospital itself has invested in the adoption. You know, we have a digital health office, we have an incredible number of experts in digital health thinking about how these tools can be adopted through thoughtful, inclusive design. So really thinking about who they're serving and who's being left out, and creating this sort of data-driven approach around design and outreach. But we have built a really sizable team that is doing this work. And then clearly working on outreach and education and understanding sort of the disparities in sort of access. And we clearly have a lot of data through this pandemic to understand the differences in patients that have been quick to adopt and those who have been left behind. But again, yeah, I mean, some reimbursement for that work would clearly be super important. But right now, that is a major cost that the hospital actually had already embarked on well before this pandemic, and clearly was needed. So it was good that we had this kind of capacity in place when coronavirus hit.
Karen, you've been on this front forever. What do you think? What can we do? Do we need a code?
Well, the only question is whether we get a facility fee, right? Because that there's the technical piece, the professional and technical component, but there's also the facility itself, because the facility has to invest in, as we heard, as we discussed, the platform and the staffing to support this and the bandwidth. So a facility fee that would mimic what we have for in-person visits would be extremely helpful, as opposed to a code necessarily for that.
Colby, a lot of folks who are the folks that you speak for are not necessarily the most digitally on top of it. How much do you think helping them be more comfortable with this would be helpful? And do you see that as something where some way to support that work? Dr. Brownstein just talked about the fact that the cost that they ate. Facilities are hemorrhaging money with the loss of other surgeries and other performances. So is your community one that could use some help in getting comfortable with that virtual visit before they start on that process?
Extremely. And digital literacy, or to expand that term a little bit here, involving the health literacy, understanding what the information that is being transmitted means to them. Digital health literacy, health literacy that is being transmitted digitally. The research is very, very clear when it comes to usability and when it comes to self-efficacy regarding digital health or any healthcare protocol whatsoever. If a patient doesn't think that a healthcare protocol is going to apply to them and help them achieve their goals, they are less likely to go through with it, and they're therefore less likely to achieve the desired result. So when you have a protocol that involves digital health, if they cannot use a technology, if they don't know how to use it, if they don't understand the information that is being transmitted via the digital health tool, the protocol is not going to be beneficial to them. So it is very, very clear that usability and self-efficacy are very, very important when using digital health. And as such, the research is also very, very clear that people who are on the lower end of socioeconomic strata, and that also does often involve racial minorities, people who live in rural areas, they are most likely to be of lower degrees of digital health literacy.
Back over to you, Chelsea, and thank you for indulging my question, but I think it's something for the broader audience. We're so used to this stuff and we live it, breathe it, think about it every day. But for Colby's folks, it's different and new. And as John said, the costs of putting it all together are real. So we'd like to support, and we hope that Congressman Johnson and others can see ways to make sure that either CMS finds emergency codes or other ways to make sure that the infrastructure and the staffing that needs to go into it has some way to get supported, because that's another way to avoid that dip that you just talked about, that dovetailing, I think you described it. We need to keep that. We need to keep that up, because the more people become comfortable with it, the more they'll be willing to say, hey, this is something I need, and this is something that I want. Over to you, Chelsea.
All right, thank you. And we are actually almost at the end of our time for this panel. But I really want to thank our panelists. You all provided really valuable perspective, and we so appreciate your time and your willingness to participate on this important topic. So with that, unless any of you would like to say any final words, you can have same prerogative as Morgan and jump in if you would like.
Thanks for the great work.
Thank you.
Thank you
so
very much. Thank you very much.
Excellent. All right. Well, with that, I will turn this over to Graham Dufault as he is moderating our next panel.
Thank you, Chelsea. Yeah, and we've heard some very interesting perspectives thus far, and for everybody that is stuck with us, I know we're a little bit behind schedule, but we're back on track here with panel number 2. We are honored to have this panelist to talk about. At the beginning, Morgan introduced the set of topics by including sort of our mantra, which is what providers and patients want to know when it comes to healthcare and public policy that deals with healthcare is how are the services paid for? What's the liability proposition? And does it work? How effective is it? And so we'll focus on this panel. We'll focus primarily on the payment aspect of it that does drive quite a lot of what we see out in the market and out for patients and providers. And there's no better set of panelists, I think, to cover these issues, because we have Emily from the Centers for Medicare and Medicaid Services. We have Rachel from Duke Margolis, which has been doing a lot of really interesting research on payment models, and Jennifer Danielson from Cambia Health Solutions. And I should mention that Rachel and Jennifer are both from steering committee members of ours at the Connected Health Initiative. And so we were really pleased and proud that we have such great steering committee members and interesting panelists to share their perspectives on these issues. So why don't we jump right in, and we will have each of the panelists just give just a couple of minutes just to introduce yourselves and your organizations, and we will start with Emily Yoder.
Yes, hi. Thank you so much for having me. I'm really excited to participate and have really enjoyed the conversation so far. So I'm an analyst. I work at the Centers for Medicare, and I am primarily focused on physician payment for telehealth services. So I've been working on telehealth policy for about 4 years, but it has felt that I have done 20 years of policy making in the past 4 months. So that's been great. So obviously the experiences of my agency with telehealth is during the COVID-19 pandemic is incredibly important, just in terms of sort of modernizing payment for Medicare for communication technology-based services and things like telehealth. But actually, on a personal note, I grew up on a farm in very rural Oregon, and my parents still live there. And my father, who is a Medicare beneficiary, he does not like FaceTime or Zoom or anything Skype. That's not his deal. But because of the sort of expansions and the waivers, we were able to sort of allow payment for audio only visits, which was mentioned in the prior panel. And so my dad was able to have a visit with his practitioner over the phone. And I think that's just one sort of anecdote, but I think it really underscores the importance of this telehealth expansion.
Thank you for that. As a fellow Oregonian, I very much appreciate the reaction to high-tech capabilities. I'm from outside Portland, so not super rural, but it gets real fast out in
sure
Oregon.
Does.
So I'm right there with you. So next, how about we have Jennifer give some opening remarks? Actually, can others hear Jennifer? I'm having trouble.
How's that?
There you are. All right.
I don't know how many Zoom calls a person needs to be on before you learn the double, mute click when you're using other technology. Thanks, everyone. I'm Jennifer Danielson. I'm with Cambia Health Solutions. I oversee public affairs and policy for our company. And for those of you who don't know our company's name, We're a family of 20 different companies that really focus our work on helping to make sure that healthcare is economically sustainable and efficient for people and their families. We've got 6 different health insurance plans in 4 different states, and we cover 2.6 million people. And we focus on the commercial, individual, and Medicare Advantage markets overall. We really do work and have for over a decade to try and harness the power of entrepreneurship and innovation to deliver a number of different first-to-market digital solutions under the names that some people might recognize of HealthSpark and MedSavvy. But that entire family of companies that we work with have that same mindset and work to try and accomplish the same thing. We really do work to include innovation and have to include innovation in order to meet our long-term goals overall, as anyone in healthcare does. And work to integrate and find those intersections between healthcare and technology that can help to leapfrog over some of the problems and roadblocks and everything that we all are way too familiar with these days. So that's exactly why we decided to join the App Association and the Connected Health Initiative, and why we're so happy to be part of the discussion here today. Thanks, Graham.
Well, thank you, Jennifer. I think you described it well when you said we are way too familiar with all of these restrictions that are in place right now. And for many folks, they have unfortunately had to learn about them very quickly and find out a way of dealing with them. So appreciate you being here on the panel and look forward to the discussion with you. And Rachel, why don't you give us just a little bit of background about you and Duke Margolis?
Sure. Good afternoon, everybody, and thank you for having me on the call today. I am a research associate at the Duke Margolis Center for Health Policy, and our center has been around for about 4 years now, and it's led by Dr. Mark McClellan, who used to be a former commissioner of the FDA as well as administrator of CMS. So we have a great expertise across that sort of full spectrum, which is really relevant for COVID right now. We've got a whole bunch of teams working on therapeutics and other issues around vaccine development. And then there's my team that's working on the payment and delivery system reform side of things. And sort of specific to our conversation today, we've been looking a lot at how providers participating under value-based payment arrangements have been able to respond quickly and effectively to the pandemic. And a reason for that is partially because of their financial situation being a little bit more resilient to the declines in service volume that we've seen as a result of the pandemic, but also because these providers tend to be ones that have developed these certain capabilities that have allowed them to be successful under value-based care. And one of those key capabilities is telehealth. They've had the ability and the time to sort of invest in telehealth platforms and other digital health capabilities. And we've seen them sort of really creatively and effectively leverage those capabilities to reach out to folks, as some of our providers in the earlier panel mentioned, through chat boxes and other sort of screening tools to help them understand whether or not they should come in for testing or stay home because they might be symptomatic. So we've seen providers under those types of arrangements really be able to leverage their telehealth capabilities to effectively respond to individuals about COVID concerns, but also related to Morgan's earlier point, to continue caring for folks with other ongoing health needs. So there are folks with sort of CHF who might need to sort of be constantly monitored for potential exacerbations. They've been able to actively reach out to folks, engage with them through telehealth pathways, such as through the telephone or video if they're comfortable with it, to help monitor their health status and things like that. So I'm excited to talk more about that work, but we've definitely seen a lot of great work happening for those kind of providers who have sort of been a little bit ahead of the curve on being able to invest in these kind of technologies. And we're currently in the mode of thinking about how do we get more providers to sort of be in that similar situation. So excited for the talk today. Thanks.
That's great. Yeah. And looking forward to talking a little bit more about the value-based care angle here. But first I wanted to, so Morgan and Chelsea and the panelists have all kind of alluded to this, the fact that the recently enacted CARES Act and the prior pieces of legislation that were enacted sort of all kind of work together to create a general waiver from the restrictions in place on reimbursement for telehealth services for Medicare patients. And those are originating site and geographic restrictions in particular. And so I wanted to start with Emily and just ask, with that waiver in place, CMS and HHS generally reacted very quickly to the additional authority that Congress provided it. Wondering, how can folks share with CMS the experiences they've had with the waiver so that you all have all the information that you need to take the next steps.
Yeah, sure. Thank you. So a couple things. First of all, I do want to stress that the waivers are congressional. They require legislative action. And so although CMS has used those waivers to implement a number of additional flexibilities for telehealth, if you want sort of to see the geographic, the site of service, the practitioner type, and the technology sort of waivers continue, that really is something that sort of Congress needs to sort of take the first step there. For the things that CMS has regulatory authority over, so these are things like this types of services that can be added, that can be furnished via telehealth, things like frequency limitations, all of those sort of variety of things that fall under our regulatory authority. The most important thing that I want to stress during this webinar today is that if you want to sort of see some of those regulatory flexibilities continue, we will be publishing, so telehealth is handled through the physician fee schedule annual rulemaking process outside of the circumstances of the PHE under which we undertook emergency rulemaking to handle. So the physician fee schedule, our proposed rule historically has been published in mid-July. I can't provide any further clarification as precisely when it'll be published, but it's usually around mid-July. There's a 60-day comment period. So were we to make these regulatory flexibilities permanent, they would show up as proposals in that proposed rule. And what we need is for people to read that rule and provide public comment, really detailing their experiences with these flexibilities during the PHE, providing information on sort of the clinical aspects and information on, how do you balance patient safety and sort of evidence to kind of of experiences kind of gained with all of these flexibilities. That would be really important to us as an agency in determining which flexibilities will remain on a permanent basis.
And is there anything that you can share that you've learned thus far with the experiences of providers out there at Medicare services?
I mean, so as the Congressman pointed out, the utilization has really, really increased. And that's certainly something that obviously we've taken note of. In terms of the waivers and the regulatory flexibilities, we don't have a lot of information yet. I know that it feels like the pandemic has been going on forever. But the sort of all of those, the additional rulemaking and the waivers, it's still very early on for us as an agency, just in terms of the types of metrics that at least we in my area look at, things like utilization data. But anecdotally, the response has been incredibly overwhelming and very positive. We're still sort of ironing out little details of sort of the various kind of all of the intersecting policies. And if you listen to the office hours calls that CMS conducts, there still are questions and things that we need to iron out. But overall, it's been a really, the reception has been really positive.
So for the audience, try and participate in those office hours calls. Midway through next month, look out for the physician fee schedule as an opportunity to comment on the really important pieces of what HHS is doing, what CMS has been doing on the waiver part. So thank you for that. That is extremely useful and super glad to have those little pieces out there. Hopes folks take you up on that. So it does, with the federal government's role here being so important, I think there's also some really important perspectives to draw on from the commercial payer side. And Jennifer, I want to get your thoughts. You mentioned this at the beginning, 2.6 million insureds that you work with, and wondering what your experience has been, from Cambia's perspective. How has the accessibility of telehealth and digital health services impacted and benefited patients that are insured by Cambia?
Yeah, thank you. Much like the experience of so many of the folks that we've already heard from, when COVID hit, we stood up a number of different internal processes just to monitor what was going on. And one of the earliest, in just thinking about, how you not only meet the needs of people dealing with COVID, but continue to serve people who have heart conditions, who are cancer patients, who are diabetics, who need physical therapy services, who need behavioral health services as well. was one of the first and the foremost, for us overall. So we really did take advantage of the flexibilities that were offered and jumped in educating our providers, in implementing the payment flexibilities, the access flexibilities overall. And our numbers are similar to what you've heard elsewhere. Our telehealth claims overall are up 4,900%. That's a huge jump when was the last time any of us saw, any kind of movement like that in healthcare overall? And I know that we're all dealing with and living in unprecedented times, but we have to pay attention to numbers like that. And if we put it into perspective, in January, we were seeing an average of, 1,000 telehealth visits per week. And then in May, that number and that average was up to more than 50,000 visits per week on an ongoing basis. So, primary and specialty care have made up half of all that telehealth utilization. And, it's up significantly across the board. There are a couple of things that I think are really interesting, just to draw out as examples for, where telehealth really can be leveraged. Sometimes there's concern, and you heard from some of our physician colleagues on the previous panel, that accessing a doctor that you don't have a relationship with isn't always ideal. But the increase that we saw in the utilization of our local and existing networks far outstripped, an increase in access to some of those current vendor relationships that we had. And we paid for and covered, and provided telehealth coverage even prior to COVID. So, year to date, we've realized a 64,000 visit increase in the use of our existing network for mental health providers, while vendors in that same time period saw an increase of 2,000 telehealth visits. So for behavioral health especially, and we're paying a lot of attention to the example of what the experience in behavioral health has been. For the percent of our members who were using behavioral health previously, 85% of those, an average of 85% across all 4 of our markets, made a switch to utilizing technology-enabled visits in order to use that service and continue to use that service going forward. So we know that that's incredibly important, not only for continuing to meet the safety as it relates to serving patients during a time of COVID, when it's not as safe to go to the doctor's office for a number of them, but we're listening a lot to our providers and our customers, especially right now, about what their experience has been. And the overall feedback is they like it, which means that we're heavily invested, as we always have been, in doing things to help to continue and enable that going forward too.
Well, thank you for that. You've got some really interesting numbers there that reinforce what we've heard on the first panel and the discussion that Morgan and Congressman Johnson had. People are using it, and remind folks of the poll that we just did of likely voters that said 90% of those who use telehealth services over the course of the pandemic in the last couple of months have said that it really did address what they were looking to get out of the visit. And so I think those are powerful numbers, and I think it's eye-opening for folks to understand that in many situations, telehealth really is an effective means of visiting with their caregiver. Especially in behavioral health, I think it's a continuity of care issue, right? Where you're used to the visit every week or every couple of weeks, and being able to continue that seamlessly as possible is extremely important. It sounds like that's what you experienced in the behavioral health side of things as well.
Yeah, that's absolutely true. And it goes directly into, I know, some of what Rachel is going to be talking to us about that I very much want to listen to as well, about how you do leverage technology to get at some of those, next levels for achieving value-based care and really making those inroads and those strides to get past some of that, we call it that sort of calcified infrastructure that lives in healthcare right now that sometimes is so hard to step outside of. It's a real opportunity for us.
That's a very illustrative descriptor, a calcified infrastructure. And
adopt it and use it.
That's right. I think it's it definitely speaks to folks on the call, I think, and those of us who've been following this the last couple of years, that it really is calcified. But in light of the what Congress had tried to do with the 2015 MACRA to move the Medicare system from the fee-for-service, that is, you are paid by Medicare for each of the services. So it's an MRI of the knee, and it costs this much. And you're paid for each time you provide that particular service, the same amount, based on a bunch of different factors, to value-based care, where you're being paid for the cost efficacy, the whether or not you are improving outcomes, and all of that is kind of a complicated actuarial problem, but definitely a worthwhile one. And Congress certainly intends for Medicare to move toward that. So it's a good segue to Rachel to talk a little bit about what your research revealed about how the pandemic has impacted providers and pushed more of them, a broader swath of them, to take up value-based care models. I'm interested to hear about that.
For sure. And yeah, thank you. I think our work we've been doing work around value-based care for quite a few years now, looking at the various types of models, because, you've seen one VBP model, you've seen one VBP model, they come in a lot of different flavors. But we were just particularly interested, given, at the start of the pandemic, seeing those service volumes go way down for folks, and then sort of anticipating what the sort of subsequent effect would be on revenue, and then hearing a lot about challenges practices were having to keep staff on board. Just interested to see how the folks who are already in value-based payment arrangements were reacting to sort of that same environment. And so in our work, we talked to folks in the primary care space, in the hospital space, in a variety of different sort of provider perspectives. And for those folks that were, so value-based care, like I mentioned, our payment exists along a continuum, where at one end you have fee-for-service, the other end you have a sort of globally capitated full risk model. But most folks live somewhere in the middle, if not closer to the fee-for-service end. So, but even folks who were had just dipped a toe into into value-based care, where maybe they had a small percentage of their business paid through some sort of like ACO type payment, still were able to leverage any sort of savings they had experienced through that model to either implement new workflow processes to try to identify high-risk individuals and then reach out to them, whether that be through phone or whatever telehealth platform they already had leveraged. They really were able to sort of be buffered a bit from the financial effects that we've seen a lot of other sort of providers experience as part of the pandemic. And then just to tie more directly to telehealth, as I alluded to before, that's one of the key capabilities we really identified as folks who are operating under these payment arrangements have developed over the years. And that's simply because, or not simply, it's a complicated situation, but one of the main reasons is because the financial sort of capital that they've been able to save or sort of realize as a result of participating in these models have allowed some to sort of have the ability to invest in the telehealth platforms that they've been able to leverage now. Or again, speaking to an earlier point about you needing to have these prep calls with folks before you actually have them with the doctor for the appointment. A lot of these providers have also, given the high emphasis of care coordination in a lot of these payment models, have hired care coordinators who now during the pandemic could sort of be reoriented and pivoted to do these more outreach activities to either screen folks or prep them for these types of calls. And so there's just a little bit more sort of fluidity that could happen in the staffing that's available, the telehealth platforms that were available, as well as the third capability we identified was just a robust data infrastructure that some of these providers had access to identify their high-risk patients. There's just some more fluidity and room to sort of quickly pivot resources under those types of payment models, it seems like, because you're a little less worried about, I have such a decline in revenue, how am I going to make that up? You have a little bit more breathing room in terms of what your resources are.
So the value-based care model does, in many cases, enable a provider to reinvest in more sort of ancillary services, and to free up staff for wraparound services as well, to get people sort of up to speed on how to make use of those types of digital health tools as well. So those are interesting insights that come out of the research that you've done. And I'm curious if you have thoughts too about what that means for policymakers. Is there something that you would recommend, or an approach that you would recommend be taken either with rulemaking or if there needs to be a law change by Congress to ensure that value-based care models that you see in Medicare are not providing a disincentive, at least for the adoption of telehealth tools, or even better, providing an incentive for the adoption of those tools.
No, I think it's a great question, and I think I'll focus more on the sort of administrative end, not to put Emily on the hot spot at all, but just I think that CMMI does have a variety of models that they've been putting out and testing, and I know they recently did some sort of emergency rulemaking to adjust some of the sort of features of the Medicare Shared Savings Program, and a colleague of mine, Will Blesser, wrote in Health Affairs about that. So I think in terms of the existing models, I think we're in favor of those staying in place and still allowing folks to participate in those in the near future. So we think it's important that folks have access to and have a variety of models to pick from, because like I said before, folks are on a spectrum of sort of readiness to participate in these kind of payment models. And so if we can have a variety of models available that sort of meet providers where they are to a certain extent, I think that would be ideal. But in terms of sort of any new models or tweaks to existing models, I think that really comes down to the details that are sort of developed through the rulemaking process to sort of make sure that we don't disincentivize the use of telehealth. And sort of the three areas where I think that sort of comes into play is around quality measures. What quality measures are we using in these models? Do they consider the use of telehealth and, hopefully not inadvertently ding folks for using telehealth, or do they explicitly sort of take them into account? I think that's an important consideration. Issues around attribution too, as well, I think can be a little bit muddled sometimes by the use of telehealth. And so just clarity around sort of how does telehealth get played into attributing patients to different folks as well. And then finally, risk adjustment. I know sort of the use of risk adjustment is very important for helping providers sort of have their sort of payments or quality scores reflect sort of the patient population they take care of. And so how does the data for that risk adjustment get collected? How does telehealth play into that? I think is an important consideration as well. So I think there's many avenues through which you can try to make sure to protect telehealth as well as sort of promote it, definitely on the administrative side in particular.
Well, those are great points, and I think we couldn't agree more with those points. I know that Brian Scarpelli and our team has filed comments many times over the years with the agency to ensure that they're adopting rules that and your team there, Emily, has what they need to ensure that there isn't a disincentive and that that providers that want to create these models aren't going to sort of avoid the digital health tools because it's not clear whether or not they're acceptable under the models. So definitely a big piece that we're paying attention to. And throughout this discussion, one of the things that emerges is that we talked about the general waiver from originating site and geographic restrictions. That's on. If it's not clear to folks that are paying attention, many of you probably already know this, but that's on telehealth services, which are live voice or video interactions, and those restrictions are not on remote patient monitoring, which is a separate set of services, and that CMS has been amazing in its leadership on adopting payment codes for remote patient monitoring. And I'm wondering, Emily, if you have any thoughts on the availability of remote patient monitoring. Colby mentioned in the previous panel is now available and reimbursable for acute care. That was a clarification that the agency provided not too long ago. But I'm wondering if at a high level, you have any thoughts on the benefits of remote patient monitoring during the pandemic and then going into the future.
Yeah, sure. And actually, I wanted to build on something that Rachel had said about sort of, I think the fee-for-service sort of payment environment is one that it does make it challenge. Fee-for-service by its very nature is about paying for distinct services. I mean, there are 6,000 CPT codes, all describing sort of various procedures and diagnostic tests, and only like a very small handful of those codes describe sort of ongoing care management or other types of non-face-to-face care, which are really important when it comes to sort of globally treating the patient overall and providing payment for more things like primary care type services. RPM is a great example of those types of services. we've been paying for RPM now for, I believe, 3 years. We adopted CPT codes that described remote patient monitoring for ongoing chronic conditions. During the PHE, we heard that language around chronic conditions was sort of an impediment to using these codes to pay for management of COVID. And so we were able to, through emergency rulemaking, sort of clarify that it can be used for either acute or chronic conditions, and to sort of modify some of the billing rules around how many days of monitoring per month you have to have in order to bill for the service. So we were able to sort of provide some flexibility there as well. I think going forward, I mean, this is one of those issues that we would need to sort of consider and like potentially write about in the rule, and whether there are clarifications that we could make with the existing code set. Do we need additional codes for describing sort of a more acute remote patient monitoring? I think that those are all sort of considerations that we would have were we to kind of, again, move forward with this flexibility.
That's a great set of considerations here. And I think hopefully there will be robust participation on the rulemaking, and that folks will be able to offer some good advice on whether or not there needs to be a new code or codes adapted along those lines. And I think for that reason, it does underscore the position that we've had for a while, which is if you're too restrictive in statute on what a service is for reimbursement, it's not very future-proof that way. So you want as much of it as possible to be done at the CMS level and through the participation of the stakeholders, so that you can keep up with the natural evolution of these kinds of services. So appreciate the comments on that. It's very helpful and very insightful here. And it does, adjacent to all of these, and as we catch up, and as the Medicare system sort of catches up to digital health services, and as patients start to rely on them more, one of the natural questions that comes up, and certainly has been accelerated by the COVID-19 pandemic, is what are the privacy implications? And so, Jennifer, I wanted to ask from your perspective, Cambia Health is involved in digital health, but also as an insurer. How does the public policy around privacy figure into your decision making, and what's your general thought on where we're going with privacy?
Yeah, we all know that privacy can have, a multiple day, session unto itself. And I think that we're all pretty well versed in a lot of those discussions happening both at the national and the state level. COVID brings up the question of privacy, not just as it relates to, how people leverage technology and the infrastructure that we want to have to live around that in protecting privacy, but we touched on it in the previous panel as well. Everything related to, what data needs to be able to do to enable things like contact tracing, and in order to ultimately, truly serve, and meet the promise of what value-based care is. So we see this issue of privacy going hand in hand with interoperability, technology-enabled access, sort of these really big issues that have needed some serious attention in healthcare from a policy perspective to do just as you said, Graham, really accelerate and catch up to where the world sort of lives and sits today. It's not that we can't do contact tracing in a much faster and much more reliable and insightful way. It's that we as citizens aren't ready to trust government institutions with what they do with that data or might do with that data. So we've got the same issues in looking forward, not only responding to COVID now, but in thinking about what that response looks like, going forward for, future pandemics or outbreaks, let alone all of just the nuts and bolts of how we want healthcare to exist and to work today. So we all know where that discussion sort of sits at the federal level. We've had a lot of opportunities for, our own company in the work that we do to have a lot of these conversations at the state level. And they're grappling with all of the same questions that we are at the state or at the federal level as well. So I don't see an easy solution coming to the forefront quickly. But organizations like the App Association and the Connected Health Initiative, I think, really can step out and provide some of that leadership about what, good stewardship actually looks like when entities are enabled with and, have the power of data to do some of these really big things that we're talking about. So we expect this to be one of those top tier issues for us, for the foreseeable future and going forward as well. We've got to figure out a solution to this while we figure out, how we do further capture and enable that access and, position ourselves for future response as well.
Well, those are good thoughts, and I agree. We definitely need more advocacy around what is the right path forward when it comes to healthcare data. This is sensitive data that flows outside of the Health Insurance Portability and Accountability Act umbrella, so the HIPAA umbrella. More and more you're seeing that, right? So I think I used to work on the subcommittee that was responsible for just privacy on the House side. And I can tell you that the backgrounds of those staffers are not really in healthcare, and they need all the guidance that they can get when it comes to the considerations that you have to account for in healthcare privacy. And how do you ensure that a patient and we were big supporters of the information blocking rule to make sure that patients could have better access to their own data and request it in a timely manner and in an interoperable manner, get it sent to an app or a service of their choice that might be outside the HIPAA covered umbrella. But there are some really legitimate questions about what happens to that data and how are we going to make sure that they have equal or better protections under a general privacy law that sits adjacent to HIPAA. So we're working on those issues right now and trying to advise the drafters of those major privacy bills. There are a lot of cooks in the kitchen on these issues, so there's a lot of work to do. But more and more participation from the healthcare folks and the healthcare technology folks is definitely warranted and welcome. And so we'll see what happens there. As you mentioned, it's going to be very hard for them in Congress to establish a single set of federal privacy rules. We want to see it happen, but it covers such a broad set of different types of entities and companies and stakeholders that getting it right is going to take some time. And that's what we're here to do is follow it all the way to the end. So, but I want to give Morgan a chance to ask a question if that's okay.
Yeah, I am. Can you all see me? So this is a fairly healthcare nerdy question, mostly for Emily, but I'd love to have Jennifer and Rachel weigh in. So Emily, as you know, Dr. Ruban and I both serve on the Digital Medicine Payment Advisory Committee that helps to devise those codes that you talked about earlier. When you mentioned the fact that CMS has been paying for digital services for 3 years, one of the things that we really ran into was Code 99041 was not particularly widely used, in large part because it had a requirement of 30 minutes per month of physician time, which when you think about what you want out of a daily check-in with a patient, you don't want the physician spending 30 months. You want that physician being able to look at a dashboard and kind of say, okay, Mrs. Jones is taking her meds. She's in the green zone. Mr. Jones, because most men don't take their medication regularly, medication adherence is a problem. Mr. Jones is in yellow. I need to have a staff person call them and let's set up an appointment and see how we get back on track. But a lot of the codes, and I'd love to know what you guys think, how do we do a better job with the codes to meet where technology is? Because technology is about eliminating time-wasting activities for physicians and allowing them to practice at the top of their license. So, Emily, what can we do, and how do you guys battle with that? And then Rachel and Jennifer, I know that's super specific, but it's down to, how do we do a better job of not wasting the time of, frankly, as we know, working with the AMA, they're going to be 90,000 physicians short by 2025. We don't have enough doctors. We need codes that empower them to do more with less, or less with more time, more with less time and allow their staff to help in. So I thought it was great you mentioned how you guys have been paying, but we both know that's been something that we've still been struggling with to make it intersect with the tech. I'll go to me.
Yeah, absolutely. I mean, I think it really does go back to some of the challenges that are just inherent to fee-for-service. So the situation that you're describing, where you have sort of a dashboard and the physician is sort of can monitor sort of multiple patients' needs, kind of not simultaneously, but nearly simultaneously, like that is a very, very difficult concept to put into fee-for-service coding. Because it's like, because we have to pay for, you know, individual services that are sort of physician, patient, like that's sort of the definition of a service, at least the way we think about it. And so something like what you're describing is like, okay, well, how is the practitioner going to keep track of all of the minutes for all of the different patients? And somehow there's like, and then like document all of that and put it and deal with the medical record. And it's a very, very challenging sort of conceptually, just because of how fee-for-service is structured. And where we've tried to kind of not get around that, but like pay for things like ongoing care management or remote patient monitoring, it does become, that is just such a challenge, like documenting all of the time spent and like making sure that you're not spending time providing a service to two patients simultaneously, things like that. It's very, very challenging just based on the nature of the structure.
Jennifer or Rachel, since we've all talked about this on a few occasions.
I'll just hop in and say, you know, I'll cop sort of, you know, not the expertise in these specific codes, but following up on Emily's point, I think again, it's a nature of fee-for-service and having to tie everything to one little thing. It's an inherent barrier to trying to sort of really have care, the way care is actually delivered, reflected in these sort of individual units of time and money. It can be it's just challenging, and so I think it's another sort of I don't want to say evidence, but sort of sign that maybe that system is not the best in all situations. Maybe there's still debates about what percentage fee-for-service should be appropriate, but I think this is just this particular issue I think just highlights the need for some areas are just perhaps not the best suited for fee-for-service.
Yeah, I would say just one thing real quick, sort of following up on that. It really is the inadequacy of the coding really comes down to how do you sort of, it's easy to say, okay, here's a procedure, we're cutting into a person, like there's a code, like that is sort of easy conceptually, but what about when it's just sort of spending time with patients and like the kind of work and the cognitive work that goes into sort of spending time with patients and sort of quantifying that time and fitting it into sort of a structure that is sort of, patient, practitioner, procedure that's very, very, just very difficult.
Yeah, and from my perspective, everyone else has hit the nail on the head. You're always going to be playing catch up if you're living on sort of that, level of specificity. There's no way to stay ahead of, where the advancement and, going back to some of the conversations related to privacy, the technology will always outstrip, and the power of what we're able to do in these days and years going forward will always outstrip how quickly we can allow laws and regulations to keep up with that. So I think it was Graham that mentioned it earlier, finding that right balance between, and value-based care being the example of that framework within which innovation and movement can actually happen. Everyone else hit the nail on the head.
And just one last comment, because the former geriatric nurse in me just would be unhappy if I didn't say this. I think the patient population that folks are going to be taking care of, or have been and will continue taking care of, folks with advanced or serious illnesses, I mean, they are the folks that don't need a specific procedure, or what they need is the time that Emily mentioned, and that's really hard to capture in a code. But that's what's needed for high quality care and to make decisions about going into the hospital related to utilization. I think the patient needs too are not aligned with that type of approach all the time as well. So.
Thank you for indulging me, but I think it's something that we work on at the, as part of those who develop the codes that Emily talked about. These are ongoing conversations that we're all trying to figure out is how do we make sure that the behavior of the code system matches the behavior of what patients need. And I'll tell you, physicians and their staff are very frustrated by, I want to do this right. I want to meet that patient where they are. I want to provide them the best care I can. but the code base drives me in a direction that asks me to do things that I might do differently if I didn't have it. So it's certainly a frustration. And Emily, I want to thank what you've done and everyone else at CMS has done during the pandemic to try to basically build the airplane while we're still flying, and get the code base to make some sense and make it work. It is one of those, we're still midair and people are kind of, bolting the wings on some of these things. So really appreciate your work on this. And Graham, Jennifer, and Rachel, thank you very much for this panel. And I'll turn it back over to Graham.
Oh, I'm glad you had a chance to ask. As a member of the Digital Medicine Payment Advisory Group, it's always nice to have a true expert join us and ask the right questions. So thank you, Morgan. That's great. And it does, all this kind of underscores the need to provide certainty in the statutory provisions that cover Medicare reimbursement and reimbursement in general, and to sort of future-proof. And to that end, we've been asking, our advocacy is centered around making the waiver permanent, but also what would be even better would be to remove the originating site and geographic restrictions from the statute altogether. And that way, we don't have to worry about the waiver lapsing or coming back into force, or the restrictions coming back into force. So those are just little pieces I want to throw out there as really important aspects of what we're doing and how we're advising Congress on this. But we've sort of reached the end of the questions that I had prepared, and we do have at least one question from the audience that I did want to ask, if that's all right. We have one from an expert in this area, and this is for Emily. The question is, so is CMS really concerned about the drastic increase in utilization of telehealth as a matter of cost, or is the approach sort of to take a longer term view on overall cost of care?
So in terms of just the response to the pandemic, or kind of broadly, were these flexibilities to be made permanent? Is that like, what's the context?
My guess would be kind of broadly. So taking what you've seen in the, okay, we even have that. She just clarified broadly.
Okay, awesome. So I think that I can definitely say that cost is always of a concern to us, but to the extent to which a virtual service might take the place of an in-person service, and with the resource costs for a virtual service would probably be less than were that service to be furnished in person. I think that there could definitely be just straight like cost savings. I mean, when we started paying for the virtual check-in, the idea there was to provide payment for a doctor to assess whether or not a patient needed to come in for an in-person visit. And so the idea there was that if that phone call or FaceTime or whatever, there were not technology restrictions, were to prevent an in-person service, then that would actually prevent the more costly sort of evaluation and management service from having taken place. And so I'm making payment for this service that is it's sort of much shorter. It's not as labor intensive. It's just really a check-in. We could prevent all of these unnecessary office visits. And so I think that there's a real balance between, obviously we don't want to incentivize a situation where practitioners are just calling, patients and then billing when there's not really sort of a meaningful service there. But at the same time, there's a real balance between that and recognizing that virtual services can oftentimes actually save the program money if, sort of implemented correctly.
Gotcha. Well, that's very helpful to hear how you guys are thinking about this. I know, for us, I think it's a matter of making sure that both Congress and the agency understand sort of where there can be cost savings. We've had a lot of trouble in Congress with the Congressional Budget Office where, they have a 10-year budget window. They're not really allowed to, except in certain circumstances, look beyond the 10-year window. And so realizing the cost savings kind of happens beyond that 10-year window in many cases, especially when you're talking about the investing in the management of chronic conditions. And so, it's been an exercise in trying to convince Congress to sort of look at it from a cost, a long-term savings, even though the main accounting group for Congress isn't necessarily accounting for them. So let's see. I don't think we have any other questions beyond that. Let me make sure though. Yeah, I think that's it. Unless Morgan, you have any last thoughts, or any of the other panelists, anything you think we ought to end on with before we adjourn?
No, I just like to thank our panelists, Graham, Emily, Rachel, Jennifer, Colby, John, Dr. Ruban, and of course, Congressman Johnson for this. I know this was a lot for those of you listening and those of you watching on YouTube as well, but I hope it gave everyone a sense of kind of the four corners of the discussion. And I remind everyone, going back to, the things that we really need to ask is, does it work? Will I get sued? Meaning, are there problems with privacy or malpractice that we need to solve? And of course, how does it work within a payment system that's literally 20% of the GDP of the United States? So we hope to tackle those questions. I believe absolutely, and something that Rachel noted, is we're going to have 70 million Americans over the age of 65 by 2030. 70 million. Of those, statistically, 80% will have at least one chronic condition. So to Rachel's point, this isn't a problem that would be nice to solve. This is a problem that we must solve in order to serve 70 million American citizens who will expect a level of care that's provided to them in a way that's safe, secure, effective, and doesn't basically destroy the healthcare workers who are there on the front lines to provide that care. So that's the scope and the breadth of what we're all working on, making this available for millions of Americans in a system that wasn't built for it, bolting it on or bolting the wings on while the plane flies, and then hopefully coming up with solutions that match the technology on the ground. And for that, I thank all of you so much for the work you've all put in, to the previous panel, the workers on the front line, and of course, Congressman Johnson and his co-chair, Congressman Matsui, for making this all possible. Graham, thank you to you and Chelsea as well for running the panels.
I want to thank Morgan for sticking around and not just jumping off after his initial comments were over. That's amazing. We like that. And a lot of participants have stuck with us. Thanks to everybody who listened in. Please join us in advocating for many of these changes to be made permanent, to ensure that patients don't experience that the telehealth cliff is what they're calling it now. So thank you all for listening, and please don't hesitate to reach out to us. We're actonline.org is our trade group website. And we hope to see you sometime soon. Thank you very much. Thanks to the panelists.